Yeah, and I think we are live now. Start, Shilpa madam.
Yes. So, good evening, everyone. So, I welcome you all to this third session on immunology in reproductive health. I think the past two classes have been fantastic in terms of giving practical tips and also to understand the basics. If anyone has not watched it, I would urge everyone to just start it from the first class. And today's class is chronic endometritis, and why we have included this in the immunology part of it, you will come to know after this class is over. I think this makes a lot of the relevance in terms of why we are speaking about chronic endometritis per se as a separate topic in this fertility masterclasses, because it is very, very, very important for every practitioner, especially in developing countries like India, to know and to be aware when to treat, when not to treat, and how much to treat, and also like how to diagnose the chronic endometritis. Over to you, sir.
Okay. Madam, please stay online, okay? Because we may have some internet issues today. Okay, and my screen sharing is starting. Just see if you can see the screen.
Yes, yes.
Okay. So then just hold on. Can you just see what I've signed here? I've
Yes,
signed
yes.
J.
Yes,
Okay,
yes.
fine. So we are going to be talking about chronic endometritis. Okay. Now, please remember one thing, guys. Whenever you are trying to talk of recurrent pregnancy losses, whenever you are trying to talk of more than 2 abortions, okay, whenever you are trying to talk of more than 2 IVF failures, okay, especially 2 IVF failures with euploid embryos, or if you haven't done a PGTA testing, so if you have not done a PGTA testing, then 2 IVF failures where you thought the embryo quality was great, okay, embryo quality was excellent, and endometrial thickness, okay, endometrial thickness was excellent. All right. So in these two situations, so when I'm saying more than 2 abortions, basically now if you go through my previous session, I'm trying to talk of 2 abortions. So let me just add a very important word to all this: idiopathic. Okay, so you do not know the cause for having these 2 abortions. So if you were to go through my previous class on how to investigate, you will realize that there are, apart from satisfying these two criteria, okay, the other important criteria which comes out of all this thing is a normal product of conception karyotyping, okay, as a part of having the previous abortion. So let's say somebody has had an abortion and there is a normal POC karyotyping. This is a very, very important cause which comes to our head. Okay. Simultaneously, it will also be present in a situation where there is a CDC cross match. The CDC cross match being positive. That means the blocking antibody is already positive. Okay. Blocking antibody is already positive. All right. Whenever you have this situation, the first thing that should strike your head under all circumstances is chronic endometritis. Please don't think of anything else. Okay. Now, what do I mean when I say chronic endometritis? What is the difference between acute endometritis and chronic endometritis? Remember, acute endometritis is like PID. The patient is going to give you symptoms like, pain in the lower abdomen. We don't really see fever so commonly, but pain in the lower abdomen, foul smelling discharge. Okay. When we do a per vaginal examination, then tenderness. One of the commonest symptoms which we see in acute PID is dyspareunia. Okay. All these symptoms are also absent. Okay. None of these symptoms are present to the patient. And this is a very, very important thing. Okay. Which you have to keep in mind when you are treating chronic endometritis. See, the biggest problem with chronic endometritis is almost always it is infective. Okay. Almost always it is infective. Now, these infections are going to be a variety, okay, are going to be a variety of infections. Usually, these are infections which are going to be ascending from the vagina, okay, and going inside the uterine cavity and causing some amount of endometritis. Okay, so if I draw the endometrium here, Shilpa madam, can you see the drawings?
Yes, yes.
Okay, so if I draw the endometrium here, this is going to be a normal looking endometrium otherwise, which is why I mentioned this point that endometrial thickness is normal, which is otherwise going to be a normal looking endometrium. Okay, please try and understand this concept. The only way to diagnose chronic endometritis is actually by doing a hysteroscopy and taking a biopsy and doing immunohistochemistry, IHC. If you do only hysteroscopy, you will have only surrogate markers. You will have some strawberry spots here. Okay? You will have a micropolyp at the level of the cornu. Cornual micropolyp has got no significance with chronic endometritis. You must have micropolyps which are seen in the cavity at least at two different locations. All right. You will have a patch of hypervascularity, hypervascular patch you are seeing on one of the wall. All these are probable markers. Okay, as a result of this, you come down to the other important aspect as to when should you do the hysteroscopy in chronic endometritis. Okay, whenever you want to do a hysteroscopy in chronic endometritis, it is very simple. I'll just write down hysteroscopy to be done between day 16 to day 22. Okay. Though now you will say, Array, but if I do hysteroscopy in day 16 to day 22, there will be too much of endometrium and we will not be able to understand if it is polypoid endometrium or not. You are absolutely wrong. When you do this hysteroscopy on day 16 to 22, all these signs are going to be equally visible. There is no problem. Just in case you were to do a hysteroscopy, let's say earlier, where these signs are seen even better, between day 7 to day 11, if you do, then you will see these signs even better. Micropolyps will be seen even better. Strawberry spots will be seen even better. But the problem is that your IHC correlation won't occur. And I will come to that. Okay. So please understand what happens in chronic endometritis is over a period of time, there is an abnormal vaginal microbacteria. This bacteria ascends upwards inside the uterine cavity, and when it goes in the uterine cavity for a prolonged period of time, for more than 6 to 7 months, okay, it has been causing some amount of focal endometritis inside, and that is your chronic endometritis. So what the body does, what does the immune system do to this? Okay, I will just draw everything again for the immune system. Okay, so just see. Now I will just magnify everything and show it to you. Okay, so the immune system, it works in a separate manner. All right. I'm just drawing the endometrium now. So this is just the endometrium which I have drawn. Okay. And I am taking a biopsy of this endometrium. All right. So let's assume you have a bacteria here. Okay. Please excuse my drawings. Okay. But this is a rod shaped bacteria which I have drawn. This rod shaped bacteria, if it is persistently abnormal, okay, then the body will do one thing. The natural killer cell values will initially go down. Okay. Once the natural killer cell values for this thing goes down, okay, it will stimulate something called as a B cell response. Okay. There are two cells which are otherwise important, your T cells and your B cells. But when there is a new infection, there will be a B cells response. Okay. This B cell response are actually coming from the marrow. They are coming from the marrow and they want to go and kill this guy. Okay. So these B cells will secrete something called as plasma cells. These plasma cells will go and say do some friendship with this bacteria, like how East India Company did in India, something like that. Okay. So this plasma cell guy will say, Kya bhaiya, you are a new person inside. What do you want to do? This bacteria will tell the plasma cell, Arey, nahi, I'm here to go symbiosis with you. I want to be friends with you and all these things. And in the meanwhile, it will go and cause damage to the endometrium because this is an abnormal B cell response. Natural killer cell has gone down, so the bad cytokines, okay, let me just call them as the bad cytokines, have gone up. Because these bad cytokines have gone up, just in case our poor embryo is lying down somewhere here, it is coming for implantation, talking to the endometrium, hello endometrium, I want to get implanted inside you. Body will tell him, Arey bhaiya, tum thoda chup baitho, you go besides. Okay, bad cytokines will push this embryo out. Man ke chalo embryo is like Jai Mehta embryo, it is a very ziddi embryo, and it will say, nahi, I want to get implanted. So this some of these cytokines will say, Arey, what is wrong with you? Why do you want to get implanted? This guy, Jai Mehta, will force implantation. And after there is implantation, these bad cytokines will go even further. Natural killer cells will go down even more, and this embryo will be thrown out. Okay, which gives rise to formation of abortions. But if an embryo is not implanting only, it gives rise to implantation failure. Okay, this is the basic mechanism of chronic endometritis. But when the plasma cells are predominating, and when you take a biopsy of this endometrium, when you send a patch of this endometrium for a biopsy, in the biopsy, they will prepare a nice slide, and inside the endometrial stroma and glands and all this concentration and all these things which you see, your pathologist will do an IHC staining and he will report presence of plasma cells. Remember one thing, this plasma cells is studied by IHC by two things. One is CD138 and another is MUM1. So honestly, MUM1 is a much better marker. MUM1 is done by a lot of histopathologists for testing for myelomas and leukemias and all these things. Okay, it is a very much better marker. But MUM1 is very specific to plasma cells also. And because MUM1 is very specific to plasma cells, it is very specific for picking up chronic endometritis. Okay. Just in case you want to understand how is it picked up, just remember concentration of more than 10 per high power field. Matlab, you have to give antibiotic to the patient. Very, very simple. Concentration between 5 to 10 per high power field means you have to give antibiotic plus some empirical therapy. Okay. I will come to this. And if it is less than 5 per high power field, matlab you don't treat. Okay, very simple concentration based on slide. No need to use your head beyond this. If it is more than 10, give antibiotics alone. If it is between 5 to 10, it is unconsequential. So you have to give antibiotics also. And then when the patient is trying for conception, you start off with ecosprin plus Vizolone. I'll come to that protocol when I discuss the management. Okay, and you add some empirical agents just in case you need to add them. Okay, now after I discuss all these things about this, you will tell, okay, very good, you have discussed all these things, but I don't want to do any of it. Okay, I want to, why should I spend my patient's money in testing for all these things? I don't want to waste my patient's money. I don't want to do this MUM1. I have the world's best histoscopic surgeon who is coming to my hospital. If he is telling me it is a strawberry white spot, okay, then I want to go ahead and directly give the patient antibiotics and treat them accordingly. See, you are going to be right in doing that, but you are going to be right in only 15 to 20% of the cases, because in only 15 to 20% of the cases, a micropolyp, as I mentioned, is actually going to correlate with chronic endometritis. In only 15 to 20% of the cases, your strawberry spots, which we love, are going to correlate with chronic endometritis. In only 15 to 20% of the cases, if you see an abnormal vascular pattern along the lateral lateral wall of the uterus, it will correlate with chronic endometritis. Okay. As a result of this, first you need to do an excellent hysteroscopy. Second, you need to do a proper biopsy. Third, you need a very good pathologist to diagnose and report IHC, because IHC is not a computerized reading. IHC is a manual reading. Correct? IHC is an absolute manual reading which is done by the pathologist. So please take home these points. The biggest mistake which we see, which people try to do, is that, see, majority of the fertility specialists, they don't do hysteroscopy. They call people from outside to do hysteroscopy. Correct? The guy who is coming to do the hysteroscopy does not know that the patient is having previous to abortions or previous to implantation failure. What does he look out for? He looks out for, अच्छा, endometrium दिख रहा है, नहीं दिख रहा है, ostia दिख रहा है, नहीं दिख रहा है. Okay, very good. Polyp है अंदर, नहीं है, fibroid है, नहीं है, खत्म. They will come out by looking at just this much. When they come out by looking at just this much, there is a big problem. Understanding? So you as a fertility consultant should go and educate your hysteroscopic surgeon and tell him what he should look out for. Understanding? Only then you will be able to find out and come to a conclusion. That is the first thing. Second, the biggest mistake which people do is they look at my prescription and they copy the same prescription thinking कि अच्छा, जय ने last time patient को doxycycline दिया था 21 days के लिए, मैं भी doxycycline देता हूँ. ऐसा कौन सा, उसने थोड़ी doxycycline ढूंढा है. We also give and patient will become okay. The problem is people forget that when you do a chronic endometritis sample, we always do a high vaginal swab. We always do a urine culture with this. Okay, always do a high vaginal swab and urine culture. And believe me, quite a lot of times when you do an endometrial culture, okay, when you try to do a culture from this endometrial specimen, most of the times if the vaginal specimen and the endometrial specimen is correlating to each other, okay, Then along with antibiotics, you just have to give probiotics, which is something which people forget to give. Okay, they give everything else. They give IVIG, but they don't give probiotics. Okay, give probiotics because a good vaginal microbiome correlates with a good endometrial microbiome, and a good endometrial microbiome automatically prevents chronic endometritis. Okay, with this I finish my 15 minutes of presentation. See, endometritis is a big topic, okay, and I unfortunately super specialize in this. I can do everything right from IHC till sample collection to how to send a sample from Bangalore to Bombay, what is the temperature, how to prepare formalin, how to prepare formalin vial. I have even guided people on shipping vials from India to Spain, okay, when they were wanting to do ERA testing. So I really super specialize in this, and I can speak for, let's say, 25 hours on this non-stop. But this is the condensed information of chronic endometritis which a clinician should know, and I thought I'll put down this much. Of course, Shilpa madam will come up with two wonderful questions which I have not covered, and she'll try to ask to show off her importance. But that is okay. So with this, I conclude. And Shilpa madam, you can take over now.
Yeah, thank you. So tell me this, the Nabothian cyst that we see on the scan, I mean, because
Yeah,
the genital tract is in continuum. So it need not be only endometritis, right? It could be endocervicitis, it could be salpingitis. You think like,
yeah.
I mean, if we see Nabothian cyst, we need to be a little more alert and say like we have to treat, or what is your opinion on that?
Do nothing. See, Nabothian cyst, when you are going through an office hysteroscopy and traversing it, okay, you will see that Nabothian cyst if it is large in size. If that Nabothian cyst is small in size, with the water pressure, it will get occluded and it will go by the side. So don't really give crazy amount of importance to a Nabothian cyst that you will go and you will break the Nabothian cyst. By breaking it, nothing will happen. It will regrow. Okay, if you really are so, antagonized to an Nabothian cyst, you will have to go inside and excise it. Okay, that is the only way in which it can't regrow. Otherwise, it will keep on regrowing.
Okay, so you're telling this endometritis as an immunological aspect, the infection leading to chronic inflammation and leading to an abnormal immune response, which can lead to recurrent implantation failures and recurrent
Absolutely.
miscarriages. I mean, that is the gist of
Absolutely.
your thing. It is not just
Yeah.
about the infection being there, or like, so this is related to the
Let's
immunology
say
of.
if you see, so I'll just tell you what has happened since today morning. We've started 7 patients on IVF since today morning, out of which 4 patients have had at least one IVF cycle failed. Okay. So we did an office hysteroscopy. We've sent all the 4 for biopsy. My suspicion, my suspicion is that 2 patients will turn out to be chronic endometritis.
Okay, so once you tell me this. I mean, you do the hysteroscopy, you do a histology, you do a culture, and then you do the IHC.
Embryo transfer. Yeah. Correct.
Yeah, all these among these four things. So you say that doing hysteroscopy and doing IHC has the best of the diagnosis, or the
100%.
specificity is quite good. Okay,
Very
if
good.
there is no facility for these things, so if there are consultants who are in tier 2 cities, or who are wanting to, do you suggest doing empirical treatment and then relooking after 3
If
months?
you are located in a tier 2 city, you give me just 5 days. I'm coming up with something where you can take a single sample, okay, and courier it. ठीक है? Don't worry. There is nothing, there is no difference in tier 1, tier 2, tier 25 city. Even if you are sitting in a PHC in a village, if you can take an endometrial sample, you can courier it, we will do something for you. Don't do a half-hearted effort. Do a bindas effort, full effort.
Okay. So do you do a repeat hysteroscopy in your cases who
No,
you have treated, and then
no,
do the embryo transfer? You don't.
no.
Okay. And so this molecular, that CD138, how much does it cost in your setup?
Total kharcha will be approximately less than 10,000 rupees, madam.
Okay. And your standard protocol for treating, you have told that it is inomycin or doxycycline to treat
Yeah,
the chronic endometritis.
yeah,
So do you do the treatment based on specific organisms? Like, do
yeah,
you
yeah.
wait
This
for
can
the.
change. Yes, madam. This can change. This is the therapy which I stated, which will happen in, let's say, 80% of the people.
Yeah.
Okay, 90% of the people, let's assume. Okay, but we will also add augmentin if it is necessary. Okay, we will also add phosphomycin if it is necessary, if necessary. Okay, many a times it will happen, madam, that nothing will be grown. Many a times it will happen, nothing will be grown. Okay, we also take opinion of physician. If we find that something is wrong, we will take physician opinion, infectious disease guy's opinion. Okay, and we may change the antibiotics. There are so many times where people have told us, "Arey, don't do anything, just give probiotics." Okay, that is also common, very common. So all these types of micromanagement will keep on happening, madam, based on what we are seeing. How you interpret the plasma cells on IHC is very important. Now, next
Yeah.
time I go to interpret that IHC on plasma cells, see, I am not a pathologist, okay? But I work very closely with a pathologist. We are very good friends, understanding. So what IHC he sees is what IHC I see. I can only report mum1. I don't know how to report anything else on IHC. Understanding the concentration of plasma cells really makes a big difference. And this plasma cell concentration will vary based on the period, like which day of the cycle you have took the biopsy. Understanding it will vary based on that. So if you
Yeah,
are taking the
but
biopsy very early, then it will be problem.
yeah, so there is no standardization on this IHC, especially this mum one. You are the only one, like, I read there are about, say, 200 papers since 2010 to 2022 now on chronic endometritis, and there are more and more papers which are coming up. So they say that even the fertility sterility journal, which I read, I mean, there is no standardization or there is no criteria for the number of plasma cells per high power field that you
No
need to
criteria.
take it as a criteria. So,
I
and
am
also,
giving you my criteria.
yeah. So this is your criteria as to when you treat it, and this is your criteria as to when it has to be done. That is between day 16 to day 22. But nowhere it is mentioned that this is the ideal time and these are the number of cells that needs to be there on the high power field. Yeah, but I
No.
think it's quite good because a lot of things, I think many people should be aware, especially who are into infertility practice and also people who are general clinicians also who deal with this recurrent miscarriage problems. I think this
See,
one,
recurrent abortions, no. It's very simple. Recurrent abortions mein patient wants three things. What was the cause? Can you treat the cause? And what will you do to make sure that next time I don't have an abortion? Okay. If you are able to answer these three questions, it is like doing a PhD in, like, what women want. Nobody can answer that question. No, like that, if you are able to answer these three questions, that means you will answer 99% of the questions for that particular patient. Understanding? No, why are you laughing? That is why you will be able to answer 99% of the questions. And if you are located in tier 2, tier 1, whatever, all that doesn't matter, guys. Come on. You have to treat it this way. If you treat it this way, you will give an outcome. See, if you don't give an outcome, they'll change the doctor. Why you want that? No, give a good outcome. Let them
yeah.
stick with you.
Yeah, so tell me this, apart from the immune response, do you think the chronic endometritis alters the uterine contractility? And do you think there is a role for the atosiban and such stuff like, to improve the implantation rates?
I don't know, madam. I'm
Oh,
not, I have no idea.
yeah. Okay. Yeah, it was wonderful. Thank you so much. I think it was a very, very, very